Hello, I'm Dr. Mark Cohen, Emeritus Professor of Medicine at the Mayo Clinic and Clinical Professor of Medicine at the University of Colorado Medical Center, and I'm very pleased to be with you participating in the Cleveland Clinic Rheumatology Highlights Report, and I'm particularly pleased to present the section entitled Advances in the Efficacy and Safety of the TNF Inhibitors. I have nothing to disclose at this time. These are the issues that I'd like to cover in my presentation, specifically the concept of induction versus maintenance strategies in the treatment of rheumatoid arthritis. Secondly, I'd like to look at some new data regarding retention versus discontinuation of the TNF inhibitors. Third, some updated information regarding safety. And then this question of whether or not the TNF inhibitors continue to be the, quote, best, close quote, choice for some patients with rheumatoid arthritis. So I have new information I'm excited about, and I'd like to begin my presentation with the first slide, which is a study from Japan, which really does relate to this concept of induction and maintenance in the treatment of our patients with rheumatoid arthritis. This is a study of 197 patients treated with adalimumab and methotrexate. About 35% of them were able to achieve a sustained remission, which was defined by 6 months of continuous DAS28 remission. These are patients with long-standing disease, mean duration of 7.1 years. Now, of the 35%, which represented 69 patients, 51 patients were able to discontinue the adalimumab, but in the abstract, only 42 patients were reported. This discrepancy was not addressed, nor was it addressed when I went to see the poster. At any rate, of the 42 patients now that we're looking at, 36% maintained an adalimumab-free DAS28 remission for 12 months. And even a higher number, 49%, maintained an adalimumab-free SDI remission for 12 months. Most importantly, 94.9% showed no evidence of radiologic progression during that adalimumab or TNF inhibitor-free 12-month period, and the mean functional improvements measured by HAC were preserved as well. So in conclusion, this reasonably sized, reasonably well-done study from Japan was able to demonstrate that after reaching a sustained remission with a TNF inhibitor combined with methotrexate, the biologic could be discontinued for at least a year in a significant proportion of patients. I'd like to contrast that study with the next study, which was a late-breaking oral presentation by Ron van Vollenhoven and the Swedish group, which looked at 91 patients who were enrolled in their study, then 73 randomized, and they were randomized to either etanercept 50 milligrams per week plus methotrexate, and we're really looking at those patients who were able to achieve a low disease activity or remission for 11 months after the combination therapy. At that point, so after achieving low disease activity or remission, they were assigned to etanercept 50, etanercept 25 per week, or placebo, which was no biologic with methotrexate continuation. After 48 weeks, they looked at the proportion of non-failures, which was about 52% for etanercept 50, 44% for etanercept 25, but only 13% for placebo. There were no differences between the two etanercept doses, but both were significantly better than methotrexate alone. The median time to failure for placebo was only 6 weeks. It was 36 weeks for etanercept 25 and 48 weeks for etanercept 50. So this group concluded that after reaching sustained remission with a TNF inhibitor and methotrexate, the biologic could be discontinued in only a few patients. So contrast that to the Japanese study, and then that the continued TNF inhibitor in any dose, interestingly, even the low dose, was able to maintain a stable disease state. So a slightly different conclusion, but again, really suggesting that maintenance therapy may be different than induction therapy, even if we have to continue the TNF inhibitor. The next study is a French study which used a step-down strategy randomized control approach. So rather than step up, so you add methotrexate and then you add this and you add that, what we're looking at is stepping down. So 137% on etanercept or adalimumab in DAS28 remission for 6 months were randomized to their strategy S, which was a strategy that increased the interval between subcutaneous injections by about 50% every 3 months for 3 changes, and then the biologic was stopped. If remission was not maintained, then, of course, they reversed and went up. And this was, strategy S was comparing with strategy M, which was maintaining the full therapy. Interestingly, at 18 months, 15% of the S-arm patients had completely stopped the TNF inhibitor, and 67% had been able to taper. There were not significant changes in DAS28 and HAC between the two groups, but at the end, the comment was the strategies were not perfectly equivalent because relapses were more frequent in the S-arm. So the conclusion here was that tapering of the TNF inhibitor was possible in a large number of patients without any increase in disease activity or loss of function, but we need to be quite sensitive to relapses and to treat those aggressively. So 3 different approaches to the concept of induction and maintenance, each with slightly different conclusions, but all suggesting that maintenance may be different than induction as best therapies for rheumatoid arthritis patients. Very interesting. I would just spend a second and compare this to what I've mentioned to you before, several other ongoing trials looking at the same issues. So this is really an important area of research. What we're trying to do is to see if we can maintain remission in low disease states with different combinations of drugs than we would need to induce those remissions in low disease activities. Very interesting. So I'd like to quickly switch now to comparisons of discontinuations and who stays on our drugs. The first study was from Montreal, a rheum database that they've used over the years. They looked at 249 patients, 95 on adalimumab and 154 on etanercept as their first TNF inhibitor. The 4-year survival rates for adalimumab plus a DMARD were better with the combination than versus adalimumab as monotherapy. Those numbers were 56% versus 11%, and similar numbers for etanercept plus a DMARD versus etanercept monotherapy, 67% versus 47%. And the other data is available for you to review, but their conclusion here is that the combination of TNF plus DMARD, such as methotrexate, exhibits a much better survival rate at 5 years than TNF monotherapy. I'm not sure this is a surprise, but I think it was nice to see data supporting what I think was an intuitive sense that the combination was probably superior. The next study looked at discontinuation rates. Again, this is a study which included Fred Wolf's group using a questionnaire answered by 2,340 patients. Interestingly, here you can read all the data points. There were slight differences in the ability of certain TNF inhibitors to achieve remission, and the duration rates favored etanercept and adalimumab. There was no difference between those two versus infliximab. And these differences were statistically significant. I'm not sure they were otherwise particularly meaningful. It also suggested that at about 4 years, quite a large number of our patients continue on TNF inhibitors. So I think an interesting study, probably flawed by the use of a questionnaire since certain people respond and certain people don't, probably introducing some bias. But an interesting result nonetheless. And then lastly, there was this a study from the South Swedish group from whom we've had very nicely done reports previously. So this is using their very large register, which included 3,446 patients on TNF inhibitors. with the odds ratio for achieving a sustained remission being 1.9 for etanercept, 1.7 for adalimumab. Those are not different, but versus infliximab at 1.0. So those two compared to infliximab were better. The TNF inhibitors had a lower discontinuation rates than the non-biologics. And interestingly, again, the conclusion, first or second TNF inhibitors, our patients tend to remain on them. This subtle difference between inhibitors, I'll leave to you to interpret. Interesting data in support of the use of TNF inhibitors and how our patients must like them because they remain on them. The next abstract briefly looked at responses to TNF in moderate versus high activity patients with rheumatoid arthritis. Intuitively, I think you'd expect the patients with moderate activity to have a sort of better responses, but they probably won't gain as much with regards to function. And that's exactly what this study proved. Very nice study from the Norway registry, 296 patients with moderate disease activity, 347 patients with high disease activity, looking at HAC and utility gains and remission rates. Again, remission rates much higher in the moderate disease group, but functional achievements higher in the high disease activity group. I think that makes some sense, and this nicely establishes, again, that intuitive principle. The next abstract quickly really looked at an algorithm from Curtis et al. Applied to Medicare patients with RA, a very interesting attempt to compare TNF inhibitors in large population bases using an algorithm. So this is sort of a nice example of how to do that, again showing slightly higher responses in adalimumab and etanercept versus infliximab. Interestingly, patients who were not disabled did a little better. That's probably also intuitive. But the conclusion here that you could use this algorithm to establish comparative effectiveness, and there were subtle differences, again, between the TNF inhibitors, with etanercept and adalimumab being slightly better than infliximab. Next, I'd like to turn to safety issues. Very nice paper looking at TNF inhibition in ischemic stroke. If you remember, the Swedish registry had difficulty establishing a conclusion. Here, the British Society for Rheumatology Biologics registry, which I also think is a very nice registry, was able to conclude that there was no association between TNF inhibitor treatment and ischemic stroke. Large numbers of patients. Look, 11,642 patients on TNFs, 130 strokes, with a nice conclusion that our drugs do not seem to be inducing stroke. Next, a very nice, in fact, a plenary presentation on TNF and lymphoma, again from this British Society for Rheumatology registry, again concluding, again, no evidence that the TNF inhibitors increase lymphoma risk. Again, large numbers of patients, 84 incidence lymphomas. As you would suspect, as we've seen before, there are a high number of diffuse large cell B lymphomas, but the overall risk is not higher on our drugs. Nicely done trial, actually two trials from the British registry that I think are worth looking at. Next is even a nicer conclusion in that in the French Ministry of Health study, billing data study, this group of patients, which was 2,156 biologic patients versus 256 controls, there was no increase in mortality. In fact, in conclusion, there was a significant reduction in mortality. All right, I'd like to spend just a minute or two, if I could, on this concept of TNF inhibitors being the best choice for certain patients with rheumatoid arthritis. Very interesting presentation by Odell, which was not an oral presentation, and I'm not sure why, looking, as you might suspect, again at triple therapy versus TNF inhibitor plus methotrexate as induction therapy. And it is a very interesting conclusion, reached at 48 weeks. There was radiographic and functional and clinical data. The conclusion was that RA patients who do not respond to TNF inhibitors plus methotrexate might respond to DMARDs and vice versa. So the conclusion from this trial, which was a non-inferiority trial, interesting, 353 methotrexate incomplete responders, the conclusion is that we probably should start with combination biologics rather than methotrexate plus a TNF inhibitor, since their responses are about the same. I would look at this trial. I think it's going to be used to probably dam the TNF inhibitors a little bit. I would look at this carefully, a non-inferiority trial with an interesting conclusion. And lastly, a plenary presentation by Weinblatt et al., the first head-to-head comparison of two biologics, this time subcutaneous abatacept versus subcutaneous adalimumab, 646 patients. Again, a non-inferiority trial with a very interesting conclusion that they are comparable. And again, there is radiographic data, there is clinical data, there is safety data, that these two drugs were thought to be relatively similar. At least one was not inferior to the other in the treatment of methotrexate incomplete responding rheumatoid arthritis. So the first well-done head-to-head comparison of two biologic strategies not favoring the TNF inhibitors. So very interesting days as new data emerges. I've tried to pick things of interest. I would particularly look at the last couple of abstracts I presented to you. I think they're very interesting. I'd love to talk to you about them later. Thank you very much for listening. Please look at the other presentations as well. And it's good to be with you, and I'll see you down the road. Thanks again.